informed care. And my disclosures are first. My husband does have a company called Callion Pharma. It doesn't have anything to do with what we're talking about today, though. And I did want to remind everyone that this is part of a Read and Play for a Bright Future Echo series. We have 2 more sessions scheduled as part of this series. So on June 26th, Dr. Heather Champney is going to be discussing early life obesity prevention. And on July 24th, Dr. Gayatri Jaishankar is going to be talking about how to engage with families. So we will send out calendar invitations for those upcoming sessions. Our goals today are for you to be able to screen for ACEs and social determinants of health in your clinic or setting, and then be able to describe the elements of trauma-informed care. So just a little bit about my practice setting at ETSU Pediatrics. We are a residency training clinic. We have 21 residents in total who come through the clinic and rotate through. We serve a population of children that is insured by Medicaid in about 85% of cases, so TennCare, public insurance. We have 5 or 6 FT attending faculty physicians. We are also a little unique in that we have created an integrated care setting, so starting with psychology, and then years later have added a social worker and social work team. Recently have added a registered dietitian. So our integrated team we call our behavioral health and resource team. This is kind of a timeline of establishment of our integrated care setting. So back in 2009, Dr. Jody Palaha is a psychologist at ETSU Family Medicine, and our former pediatric program director, Dr. Powers, had some grant funding to integrate psychology into our clinic as a behavioral health consultant. We also began integrating student learners to have some interprofessional education opportunities in our clinic. And then over time, as I mentioned, we've added social worker. We now have a full-time social work position as well as a full-time psychologist or behavioral health consultant position in our clinic. And we have student interns who work with that team. And you can see over the years, we have collaborated on a number of different screening and intervention projects in our clinic. And I'm just going to highlight a few of these around postpartum depression, social determinants of health, and then really focus most of the time on ACEs. So a number of clinics I know in the area in the state screen for postpartum depression. This is something that's recommended by the American Academy of Pediatrics. So we use in our clinic the Edinburgh Postpartum Depression Screener. It's a 10-item screener. Number 10 does ask about risk for self-harm. This is a screener that's passed out at the checkout desk. It's entered, the score, total score is entered into our electronic health record by the nurse, and then it's reviewed and discussed by the healthcare provider. And given that we have behavioral health consultants in our clinic, we can do a warm handoff to get some assistance if this screener is positive. So nationally, postpartum depression can affect between 1 in 5 and 1 in 9 mothers after birth. This particular screener has a sensitivity of 86%, specificity of 76% for identifying postpartum depression or risk for postpartum depression. This tends to peak at about 4 to 8 weeks after birth. In our clinic, we elected to screen at each well-child visit in the first 6 months of life. So the newborn 1 month, 2, 4, and 6 month well-child visits, just routinely. And what we have found, based on a chart review of about 750 patient charts, that in the first 6 months of life, about 24% of mothers had a positive screener during at least one well-child visit. So pretty substantial rate of positive screeners. We have a stepped care protocol for acting on screeners. So if the score is 8 or below, that's considered negative, and there's not necessarily action taken based on the screener. A score of 9 to 12 is sort of an at-risk category, and the provider would do brief education. We have a handout about postpartum depression, may do a warm handoff to our behavioral health and social work team, or to provide additional resources. A score of 13 and above is considered positive, and in our clinic we would connect the family to our behavioral health and social work team, and they can do some brief education, brief intervention, as well as relaying the score back to the mother's OB or primary care physician and providing other resources in the community. We also have a safety net protocol in our clinic if item number 10 is a 2 or a 3 indicating risk of self-harm. That could include bringing in other family members or support people, calling the mobile crisis unit, or sending a patient to the emergency room. So that's our protocol for screening for postpartum depression in pediatrics. It is a billable and reimbursable screener. And like I said, it's recommended by the American Academy of Pediatrics. I don't know if everybody can see this cartoon, but after we had a year or two experience with Edinburgh screening, and, you know, there was kind of a roadmap laid out for that. The Tennessee AAP conducted trainings on how to implement postpartum depression screening in your practice that our providers participated in. And like I said, we had this team that worked together to kind of get that screening process up and running. We, again, given that the children that we serve come from predominantly low SES families, mentioned at least 85% of our children are publicly insured. One of the next things we did is develop a process for screening for social determinants of health. There we go. Okay, so the screener that we use for social determinants of health, and we've been doing this since about 2016, we call our Team Care Screener. This was adapted from an existing screener called We Care, and you can find randomized controlled trials published about the We Care Screener. It included questions about 10 different social determinants of health. And the We Care Screener was developed in pediatric clinics that did not have an integrated care team. They did not have a social worker or a psychologist to help with positive screeners. Instead, what they did is develop a resource finder. So for instance, if a family needed help finding housing or food, they developed a tear-off sheet of local resources that the pediatrician, the healthcare provider, could provide for the family if it was positive on their screener. So we adapted the length and the content of the We Care Screener to address what we felt were the social issues in our region. And the screener that I have up there right now is a little bit longer than the one we've been using. The one we have been using just includes these first 6 questions that ask about problems reading, writing, or understanding English, finances, running out of money to pay for food, housing, or utilities, worrying about alcohol or drug use in the caregiver or someone else, exposure to violence or having someone say things that make you feel bad about yourself, exposure to feeling sad, hopeless, or worried a lot of the time in the caregiver, and then issues with transportation and missing appointments due to transportation. So those are the 6 questions that we've been asking over the past couple of years. And we explain that, you know, in our clinic, we ask these questions because we want to help ensure as much as possible that all your needs are met so that we can assist you and connect you to resources. And we ask families just to answer yes or no. This screener is passed out at the check-in desk. It's reviewed and discussed by the nurse or the provider. And again, in our setting, in addition to a resource binder that we have developed with our clinic staff, as well as the ETSU Department of Social Work, we have a team of social work and behavioral health who can help address positive screeners. And so as a pediatrician, if I have a positive screener, I can do what's called a warm handoff and just kind of bring them into the room during the same visit. So by having this integrated team in our clinic, one thing we've tried to do is really normalize psychology and social work in the resources that they can offer to families. We actually don't call them psychologists or social workers. We call them our resource team and our behavioral health consultant, because we know that there's some stigma against mental health services, and you hear the word social worker, people think that you're trying to take your child away from them. And so we've actually used different names and really tried to emphasize that these are our colleagues, our team members, and just kind of normalize the resources that they can provide. Recently, we're still finalizing the format of these last few questions, but we have added some additional questions about financial stress that might be less severe. Do you worry about how money might affect your health, personal relationships, or job performance? Ask if families would be interested in health, managing money, getting out of debt, or building your credit score. We've established a partnership with a local credit union that we could connect families to. We've also are planning to add questions about medication and gun storage and identify resource needs if we can connect them to a medication lockbox in education or a gun lock in education. So those are questions that we're planning to add to this Team Care Screener. We did a review of an 8-month period of use of this screener in our clinic. During that time, we administered over 2,000 screeners, and we found that overall 13.4% were positive screeners. And the most common issues we identified were financial issues around food, housing, and utilities, as well as transportation. And I do want to mention that the original randomized controlled trials of the ReCare screener that we adopted this one from did show improvements in referrals to resources, as well as families accessing resources by use of this screening process. So one advantage of using a screener for issues that you know are somewhat common in your population is you can more universally address this with families and limit variation provider to provider and help ensure that you can match families to resources. So this past year, really over the past couple of years, our team started to discuss adding on a way to address ACEs, or adverse childhood experiences. And we submitted and had funded a grant from Building Strong Brains from the Tennessee Department of Children's Services for a project that we called Baby Steps for Success. So we described in that proposal our experience with screening, including the Edinburgh and the Team Care Screener. Those are not the only screeners that we do in our clinic. There's a number of other developmental and behavioral screeners that we do at different ages that, again, are recommended by the American Academy of Pediatrics. So one of the first things we did with this project is map out by visit. So this goes from birth through the 5-year well-child visit, the different screeners that we do, because there's quite a few of them now as we've added on more at a time, and identified where we might add on screening for ACEs. So we, in our protocol, have implemented ACE screening for the parent or caregiver at the 1-month well-child visit, and then ACE screening that the parent or caregiver fills out about the child annually starting at the 12-month visit. And this project goes through 5 years of age. So one of the next things I did is I had the opportunity to participate in training in trauma-informed care, as well as a Train the Trainer course in trauma-informed care that Becky Haas, who's on the call, and Dr. Andy Clements in the ETSU Department of Psychology conduct periodically in the area. And this is based on SAMHSA training and resources. So I am going to share some of the resources that they shared with me, with you, starting with this ACEs primer that's from KPGR Films. It's just kind of an overview of what are ACEs and why should we care about them.
What does your parents' divorce have to do with your risk for heart disease? If your mother had a drinking problem when you were growing up, are you more likely to suffer from depression as an adult? Here's what you should know about ACEs. ACEs stand for Adverse Childhood Experiences, extremely stressful events that can happen to a child growing up. Some experiences are so stressful that they can alter brain development, as well as the immune system, increasing the risk of lifelong health and social problems in adulthood. The term comes from the Adverse Childhood Experiences Study, landmark research that shed new light on the root cause of everything from stroke and liver disease to substance abuse and mental illness. In the late 1990s, an epidemiologist from the Centers for Disease Control and a preventive medicine doctor at Kaiser Permanente set out to understand the association between childhood experience and lifelong health. They asked over 17,000 people in the Kaiser Health Plan in San Diego about their health history, as well as difficult questions about their experiences growing up. Anda and Felitti tallied up 10 different kinds of adversity in this largely middle-class and college-educated population. They were stunned to see how common ACEs were. 21% of all respondents were sexually abused as children. 19% grew up with someone who suffered mental illness. 28% had been physically abused. And 2 out of 3 respondents had experienced at least one ACE. The researchers next looked at how someone's ACE score, or the number of adversities they experienced, related to a wide array of serious health and social problems. They saw that the more ACEs someone had, the greater their risk for poor outcomes compared with someone with no ACEs. Someone with an ACE score of 4 had twice the risk of heart disease and cancer. Someone with an ACE score of 5 had an 8 times greater chance of being an alcoholic. And those with an ACE score of 6 or more, on average, died 20 years earlier. With every major problem they looked at in the ACE study, the risk went up for each additional adverse experience in childhood. As Dr. Robert Anda says, what's predictable is preventable. It's important to remember that ACEs are not destiny. ACEs are a tool for understanding the health of a population as a whole. For individuals, an ACE score can be a tool for understanding their own risk for health and social problems, and empower them to make changes for themselves and their children. ACEs tend to get passed down from generation to generation and are common across all income levels, races, and cultures. But increasingly, people of all different professions and backgrounds are coming together to discuss how ACEs affect their communities. They're finding new ways to treat and prevent ACEs. Many doctors are starting to screen their patients for ACEs as part of their medical history. More schools are becoming trauma-informed, considering the source of problem behavior when disciplining their students, instead of immediately suspending or expelling them. To learn more about interrupting the cycle of adversity and improving health and well-being for the next generation, please visit kpjrfilms.co.
So this original ACEs study was conducted in a upper middle class, mostly white population, and the researchers found that ACEs were common and universally found in the conditions that they looked at, health and behavioral health conditions, that there was a dose-response relationship between the number of ACEs experienced and these health and behavioral health condition risks. This study is decades old. It's not new. One thing that has been researched and found over the past couple decades is that ACEs and toxic stress in childhood actually affect brain development and brain architecture. So these neural connections are still being formed after birth, and experiences in childhood, whether they are positive or negative or toxic, affects how those neural connections are made, and then ultimately affects future childhood and adult health and behaviors. So there's all different types of stress, and all of us experience stress in our lives. Some stress is positive, and it's kind of a normal and essential part of healthy development. More severe stressors like loss of a loved one, or a serious injury or illness, maybe tolerable stress. And then there's toxic stress. So this is experiencing strong, frequent, or prolonged adversity. So examples might be physical or emotional abuse or exposure to violence. My daughter's soccer coach likes to talk about the differences he's observed in soccer players who have experienced a lot of adversity in their lives and overcome it, like some of his players that he's coached from overseas in other countries, compared to players who really experience very little adversity in their lives. So certainly some stress, some adversity, again, is part of normal and healthy development. And our coach describes that the stress and the adversity that players might experience on the field are good for them. Particularly if that's some of the only adversity they've experienced in their lives, it's going to help them develop that commitment, that drive, those decision-making skills that are going to make them an excellent soccer player. That's very different than what we're talking about with toxic stress, as I mentioned, that's been shown to even change the brain architecture. So the one point I want to make is that it's the experience of the stressful event that's important, not necessarily the event itself that's traumatizing. So it depends on whether this stress or trauma, how it happened, when, where, and how often, that will determine the outcomes. Factors that increase impact, so early occurrence of ACEs and stress. Situations that are lead to blaming or shaming, or feelings of blame or shame in a child. Being silenced or not believed. And then most certainly if the stress is inflicted by a trusted caregiver. We've all seen patients that look like this, children or adults that have avoidant behaviors, are disconnected from their peers and the activities happening at school, have acting out behaviors angry behaviors, or fearfulness and hypervigilance. These can all be symptoms of trauma. I cared for a boy in a family recently who was coming into the clinic very frequently or going to the ER very frequently due to just frequent illnesses, pneumonia, and ear infections, upper respiratory tract infection. Was also having behavior problems at school, acting out behaviors, making threats against other students. He was also failing multiple grades in schools. You know, with further exploration, we realized that this child, by communicating with the school, had a lot of absenteeism and tardiness, and that he was also a victim of bullying himself at school. Kind of diving further into some of his other experiences, we identified violence in the home, history of divorce and separation of his parents, mental illness among parents and caregivers in the home, as well as some effects of poverty. When our psychologist did some assessments of this child, it was clear that he was suffering from depression and post-traumatic stress disorder. And by treating him and kind of getting a complete picture of not just what was wrong with this child, but what happened to this child that was leading to some of these behaviors and conditions, by getting him the treatment that he needed, he's now improving. So that's what trauma in children can look like. What about ACE's prevalence in children in terms of violence and abuse? Because certainly there's, as you saw, different types of ACEs on that list. So are certain adverse childhood experiences going to affect the child differently than others? Well, yes and no. That original ACE study identified clearly that it's also the number of different adverse childhood experiences that are associated with poor health and behavioral health outcomes. But there are differences in types of ACEs. And then again, it's that experience, how they experience them, that can affect outcomes. But what we know is that about 71% of children are exposed to violence each year. 3 million children are maltreated or neglected each year. Up to 10 million children witness violence against their mother each year. And 1 in 4 girls and 1 in 6 boys are sexually abused before adulthood. If you look at children in juvenile justice settings, 94% of children report having experienced childhood trauma. So definitely associations with ending up in a juvenile justice setting or criminal activity. You can see that there is an intergenerational pattern that can develop. So, and if we could eliminate child maltreatment in America, we could potentially reduce depression, alcoholism, and drug use, suicide, domestic violence, and the need for incarceration later in life, and then hence start to break this intergenerational, multi-generational pattern of ACEs and trauma. We know in this region we've had a significant issue with drug abuse and in utero exposure to opioids by children over the past decade or two, and particularly around prescription drug abuse. What about trauma and associations with substance abuse? Well, we know that if you look at women, about 75% of women in substance abuse treatment report a history of trauma. Overall, about 65% of substance abuse treatment clients report this history. And homelessness, about 92% of homeless mothers have severe trauma histories. So, can we prevent the long-term behavior and health impacts of early life stress and neglect? Yes, we can. So this is called fostering resilience. So we we know that when a child's positive experiences outweigh the negative experiences, the child's scale can tip toward positive outcomes. So if resilience has been fostered in a child and in a family as they face adversity, that they can still have a positive outcome. So think back to the fact that those neural connections are still being formed after birth. So a child who has a positive environment and caregivers who are loving and supportive, those neural connections are going to be made in a way that they are going to have a higher chance for better health and behavioral health outcomes. So, for example, the concept of serve and return. So think of a young child as they learn how to smile or coo or talk. As they do that, if they have a caregiver who smiles and talks back, or when they cry or they're scared, they have a caregiver who appropriately reacts in a caring way, tries to help the child, that serve and return experience. They do something and they have this response, helps to build those positive neural connections. On the other hand, those negative experiences and adverse childhood experiences can have the opposite effect. Think of stress and resilience as a smartphone or iPad that needs a charging station. So, and this can affect people throughout their lifespan, not just children, but remember, the younger the child, the more significant the impact can be. So stress drains our batteries, but resilience factors can help recharge us. We all need charging stations. Young children have to be charged by those nurturing adults who know what they need and know how to provide that. Charging stations will change over time, and they're going to be different for different people. As we get older, we should become mindful of who or what our charging stations are, who or what are the positive, helpful influences in our lives. And these could be a supportive parent, a grandparent, a coach. It could be your faith, it could be a hobby, it could be exercise. But being mindful of those is something that's important as we get older. Thinking about how you would interact with a child and adult who's experienced ACEs or toxic stress. So one of the important messages you can give is that no matter what happened, it happened to them. They did not cause it. One of the most important things you can do is give them a chance to tell their story, but don't force them. And, take time and learn how to be an empathetic listener. So healing can start when a caring person is aware of the other person's traumatic experiences and is empathetic, continues to care and listen. ACEs are not destiny, so certainly some children are more susceptible than others to toxic stress. If the parent or caregiver cannot play that buffering caring role, there can be other adults, teachers, healthcare providers in a child's life who can help to serve that buffering role. There is capacity to heal and repair at all different ages and across development. We know that interventions can make a difference. And as the speaker in the video mentioned, what predictable should be preventable, right? So if we're aware of these associations and risks, how can we prevent them? So let's talk a little bit about trauma-informed care and trauma-informed programs. This is from SAMHSA, the 4 R's of trauma-informed programs. So realizing the widespread impact of trauma and understanding potential paths for recovery, being able to recognize signs and symptoms of trauma, responding effectively by integrating your knowledge of trauma into your organization's policies, procedures, and practices, and then seeking to actively resist re-traumatization. So that's definitely something we can think about in healthcare. A lot of the things that we do in terms of procedures and encounters may actually be re-traumatizing. How can we minimize that trauma and understand that's particularly important in children and people who've experienced childhood trauma. Trauma-informed care and services really helps you to focus on the whole individual in the context of their life, and can help facilitate recovery, growth, resilience, and healing. A trauma-informed approach is going to take some training with providers so that they can help gain the knowledge and skills to help support individuals who face trauma or maybe facing trauma currently, and that it's more than just being able to provide resources, but to gain that perspective of the person's psychological and emotional needs, and again come from a perspective of empathy, where you're not going to blame an individual, but start to understand how many factors have come together to create issues in their life, and how can you move forward from that. So finally, I'll talk about what we have done with the Baby Steps for Success project in our clinic. So as I mentioned, our goal was to implement screening for ACEs. And this is a picture of the screeners that we elected to use. The one on the left is a screener for parents or caregivers, and the one on the right is a screener that parents or caregivers complete about ACEs in their child. And I'll show you those a little bit more close up. So we explain these, that none of us grew up in a perfect family, that it's helpful for us as your child's healthcare provider to know about the experiences you've had while growing up. It can help us support your parenting skills through challenging times. And we know that, you know, growing up in unsafe or dysfunctional homes is only part of anyone's story. We know that the ability to bounce back is just as important, and that resilience can be nurtured and developed with positive experiences and relationships. The 10 questions that are asked on this screener are in line with the 10 questions or ACEs that were explored with that original ACE study. Our team elected to start with an ACE screener that would be brief, and that we would hopefully feel like parents and caregivers would be comfortable being honest about their experiences. So this screener lists those 10 ACEs and then simply asks how many applied to you as a child. Write the total number in the box, as opposed to a screener that has someone answer each of those ACEs, yes or no, this applied to me as a child. So again, we did that for brevity and in the hopes that we would get you know, more comfort with answering these questions honestly. The child's ACE screener is similar. Again, a list of those 10 ACEs, and parents and caregivers are asked to write the total number who apply to their child in the box. We made one adaptation to the child screener because our team was uncomfortable with the fact that that total number in the box could be comprised of an unreported or ongoing issue with child abuse or neglect. So we pulled out a couple of the items and explained, because we have the responsibility to report any concerns you have about a child abuse or neglect, we'd like you to just go back and answer these 2 questions, yes or no. These screeners we adapted from Dr. Nadine Burke's Center for Youth Wellness Screeners. Dr. Burke was actually the physician who was pictured in the video I showed earlier. And she and I went through the same residency training program out in California, so I knew her previously. Her Center for Youth Wellness website does have a mechanism for anyone to go in. You do have to register, but you can download her materials and screeners for free. So Center for Youth Wellness. As I mentioned in our screening schematic, back a few slides, the parent or caregiver screener is given at the 1-month visit, 1-month well-child visit, and then parents are asked to complete a screener about their child starting at 12 months of age annually through the 3-year well-child visit. Our screeners are given out when they first come into the clinic, and then they are scored, and that score is entered into our electronic health record by the nurse, and then they are reviewed and discussed by the physician or healthcare provider. At the same time the screener is distributed, a handout on ACEs and building resilience is also passed out for the family to take home. So this is a handout that our team developed. We reviewed resources that are online from other organizations to develop this handout. And you can see on the front, we do emphasize that ACEs are fact, not fate. We talk about abuse, neglect, problems in the home, as well as other potential adverse childhood experiences, such as bullying. And then have a list of ways that ACEs can affect the health and behavior of children and adults. On the flip side, we highlight the 5 protective factors and list ways under each protective factors that families can help to build resilience. So specific small things they can do, activities they can do as a family to help build parental resilience, social connections, gain support, concrete support when there's stressful times or times of need, build knowledge of parenting and child development, as well as the social and emotional competence of children. We have developed a stepped care protocol for addressing our ACEs screening results, and I feel like we're still in the process of fine-tuning it. So I don't have a schematic up there to show you, but I'll tell you a little bit about the interventions and programs and resources that we'll try to connect families to based on their ACE screening result. So the Incredible Years is an evidence-based parenting program that has, for the most part, been conducted in group visits. And it's been shown to improve parenting skills. It's been shown to reduce the risk of child abuse and neglect. And it's recently been adapted by the developer into a intervention that can be delivered in the primary care setting by pediatricians during well child care in the first 9 months of life. So we had 2 of our staff trained in delivering the Incredible Years as part of well child care. And what it is an interactive video-based program. So there's, we have a little portable DVD player that we show the Incredible Years video clips on to parents and caregivers, and then discuss those video clips. And it covers topics like feeling supportive as a new parent, what you should do when baby cries, how to talk to and play with your baby to help them learn, how to help your baby feel safe, building in routines, and then talking about, as babies get older, kind of their emerging sense of self. So, and again, it includes some practical tips, and it can be integrated into the well child visit during about a 10 to 15 minute period. And this just shows that the different topics that are covered at the different visits in the first 9 months of life. So for parents or caregivers who report an ACE score of 2 or higher, our current protocol, we would offer those families the Incredible Years during well child visits in the first 9 months of life. I will say that we have so far just rolled out screening with a couple of the providers in the clinic. We didn't start doing this clinic-wide, and we're glad that we did it that way. So there wasn't a great roadmap like there is for screening for postpartum depression in pediatric primary care, for screening for ACEs. This was new territory. And so by starting small and screening patients with just a couple of providers, we've been able to be responsive and kind of adapt our protocol as we go along. We're still kind of struggling with the ability to match families to available resources in our clinic and resources in the community, and kind of balance what we're able to do during the 15-minute or what's supposed to be a 15-minute well-child visit. We're using sort of a quality improvement approach. We have a process in our clinic called champion teams. So we had a small group of providers who helped to develop this program as part of a champion team. And we're continuing to have huddles a couple times a month to discuss how things are going and make changes. So the Incredible Years is one resource that we're offering as part of that step care protocol in the first 9 months of life. The other resource, and this is something that we've been able to build with grant support, is a program in partnership with Families Free, which is a local nonprofit organization and licensed substance abuse treatment center, as well as a partnership with the Northeast Tennessee Regional Health Office to connect families to Nurturing Parenting and the Hugs, Help Us Grow Successfully program. So our step care protocol currently, if the parent, caregiver, or child's ACE-score is 4 or higher, we would try to connect them to this community program. So staff from Families Free can meet with families either in their home or at another location that's convenient for them to deliver this Nurturing Parenting program. And this is another evidence-based parenting nurturing program that has been around for quite a long time, and it's a program that Families Free has been offering, particularly in the setting of maternal substance abuse during pregnancy, and helping families recover from that. They've been doing that for quite some time in our community. For primary prevention, they are offering at least 5 sessions. There's a lot of different sessions to choose from in the Nurturing Parenting curriculum. They're offering at least 5 sessions to these families who have an ACE-score of 4 or higher. And these center around helping children grow and develop, how to nurture your child, stress management for the caregiver, discipline, how to communicate feelings, how to celebrate traditions, culture, and spirituality, and how to make good choices. The other program from the Department of Health, the HUGS program, in this program, coordinators from the local health department meet with families in their home. They can help with screening for potential developmental issues, provide health and parenting education, and help families connect to resources in the community and just promote health and wellness in the family. And that's something that can be done in bi-monthly or monthly home visits. To connect families to these services, we actually created a release and referral form. Because this is a new program, because these are sensitive issues that we're communicating, and also because what we've done with these partners in the community is really try to integrate them into their team. We want families to be aware of what this program's about, and that we'll be communicating with these other providers about their family and their child's care. So I know you can't see this, but this is a form that we developed and was completed by our privacy officer. I mentioned we've really tried to integrate these organizations into our team to the extent that we've got contracts with them. We actually are able to share parts of our electronic health record, and we've created a case management list of families who are in this community program so that we can kind of follow up on outcomes of referrals. The other thing that we've done with our ACEs screening is link it to a couple of the existing programs that we had in our clinic. These programs include Reach Out and Read and ReadNPlay for a Bright Future. These are programs that can help build resilience in families. They're centered around that serve and return concept of positive interactions between a parent, caregiver, and a child. Reach Out and Read, we give out children's books and talk about the importance of sharing books every day with your child. Linking this to the ACE score has just been a really good reminder for us as providers to make sure we give them that book and maybe spend a little bit extra time of talking about how do you use books with your child. the Read and Play for a Bright Future program, we have a number of books or booklets that we've developed for use during well child care, in infancy and early childhood. This is a picture of our baby book that has tips and suggested activities that are based on bright futures from birth to 18 months of age. Again, the ACEs screening is a good reminder for the provider to talk about the baby book, take the baby book out, and look at it with the family. As part of Read and Play for a Bright Future, we've also established partnerships in the community that include support groups and community events. And again, our ACEs screener is a good reminder to give out the flyer for these support groups and our community event flyer. These are going to be opportunities for positive interactions between children and families. So just in our remaining, I think we've got about 7 minutes left, and I definitely want to have time to take some questions at the end. I think Dr. Tolliver is going to read through this case briefly with us, and then we'll take some questions.
And tell me if you can't hear me. I have construction going on in the background here as they're tearing apart our clinic.
I hear you.
So we wanted to just give an example of what this would look like practically using our screeners. And so you could imagine you're seeing a 2-month-old baby and Abby Rose, and mom had taken Subutex daily during pregnancy. And after giving birth, Abby had spent a couple days extra in the hospital, had been growing well in the 30th percentile during the first month, but fell off to the 5th percentile when you're seeing her today. And her height and head circumference are following the previous curves. And I don't have the, okay, thanks. So the orange one on the left is our social determinants, the team care screener we went over. And what would happen is the pediatrician would review this even prior to going in. So before even meeting with the family, able to see that financial resources are low, that mom may be feeling down or depressed, problems with transportation, even getting to the clinic, as well as worrying about how money is affecting the family and health. And then on the right, we have the Edinburgh score. We can note mom's not suicidal, but overall, she is scoring clinically significant in a 15. And so kind of matching up with the team care screener in terms of being worried about her own mental health. The ACEs score that mom filled out for herself was a 9 out of 10, which would be very high. And so through all of this, we just try to use that as information to be able to kind of formulate our approach as we go into the visit. And so in terms of the Edinburgh, we probably would want to delve deeper into that. The pediatrician often does a warm handoff to me so I can do a brief intervention, a lot of times accepted as a commitment therapy-based intervention, and I would be able to help get the family connected in, the mom connected back to her OBGYN or PCP. And for these higher need moms, we even sometimes will call up there and try to get them an ASAP appointment. And then we would do a handoff to our resource team as well to follow up on the orange team care screener. And through all of this, because of the ACE score and the program we have going on, the family would qualify for the Incredible Years intervention, that video vignette-based intervention that I do with families, as well as, if they wanted to, the option to go to Families Free or the HUGS program. And then the pediatrician obviously would address any concerns about the child's weight and development. So that's just kind of a practical rundown of how all of these different components are integrated together. And one question this would be an example of something called an eco map that our social work team does that looks at all of these different areas of need and is able to draw different types of line indicating whether that's a source of support or a source of stress for the family, and just a quick visual representation that they go over with the family and can reference back to, trying to highlight folks' strengths. And so overall, we talked about how screening for ACEs and social determinants can really help provide this patient-centered care. And we found that we give a ton of screeners, and sometimes I think we get overwhelmed by them, but in the end, they really do serve a good purpose and help us find these patients, because they're out there whether or not we screen for them. And through the 4 R's that we talked about, one question I had for you all was, what practical ways are you already providing trauma-informed care in the settings that you work in? Or what ways, kind of based on this presentation, or what ideas do you have for implementing some ideas like this? I'd love to hear your all's thoughts about what you're currently doing or might think to do.
Yeah, so we'll make sure you unmute yourself, and we'll make sure we have you unmuted. So if you have any reactions or response to Dr. Tolliver's questions or questions for us, we have a couple minutes for discussion. Can you put the pictures back up on the board, and we'll just, anybody have any comments or questions? I think Dr. Champion.
This is Dr. J.
There you go.
Yes, can you hear me?
I can hear you. And Dr. Champney, I think, was trying to speak too. I saw your lips moving. Go ahead, whoever wants to start.
Not sure why I'm not unmuted.
We can hear you, Dr. J. Any questions?
My primary practice is in the emergency room, so we have a lot of the same demographic. I actually have a lot of your patients from your clinic that come to us because they don't have the coping mechanisms sometimes just to make it to the clinic. So they come to the ER at different hours when they have rides, or when they get off work, and if they have jobs, that sort of thing. So I know for me, since doing this training and some of the things I was doing before, is I actually, although I don't have the time, spend a lot more time trying to facilitate something for these patients. Even if it's just a little tiny something that gives them a next step, and find that writing down specific directions in a very plain, simple use of English helps them a lot with navigating the system a little bit, and understanding that they can, call the clinic at any time and actually speak to a resident who's on call, or those types of things. So it does, utilizing this thought process, I think, even if you don't do anything specific with the screeners, and if you don't have a big team of folks that can help you, just a tiny little something is really has a lot of impact and has a lot of ability to empower the patient to do something a little bit more than what they think they can do.
And I think part of it is just the mentality that we bring to it too. There was one quote about ACEs that was saying, we should try to transition from thinking about what's wrong with a patient to asking kind of what happened to them. And so trying to understand their behavior and their functioning in the context of what they've experienced so far is challenging sometimes when they're coming into the ER a million times, when they're coming into the clinic a million times. But I think this approach might help us get some of those underlying causes more and treat that, rather than just treating the symptoms.
I also think it helps a lot with compassion fatigue from the provider. So if you can really switch the thought that this person just doesn't know how to do this, and they're here driving me crazy, and this sort of thing, and you switch and say, okay, this person doesn't have the resources that I have, and this person has suffered trauma that perhaps I have experienced in a different way or not suffered, then I find personally, when I redirect that I have a deeper well of compassion. And when I reframe it for my nursing staff, who frankly work a lot harder and longer hours than I do, it helps them as well, just from their perspective, be able to kind of remove that kind of component to providing care to these high patients, it really does help expand that a bit.
I would so agree, Heather. And hey, this is Dr. Jayashankar. For some reason, my unmuting was not working off my phone, and I was just down the hallway. But I really, the things that we've done, the social determinants of health screener for about 2 years now, and then we've added on the ACEs screening, and I've been one of the piloting persons in clinic. And the things that I have drawn from it, one, like you said, it definitely reframes how you think about the patient before you ever enter the room. And for those of us that work with trainees or residents, I've seen a huge difference in the way that patient is approached. Rather than the resident coming and telling me, oh, this is a 6-month-old, they never have been here for shots after their 2-month mark, they were late for their appointment today, blah, blah, blah. I actually get the other side of the story, and I'm told, this is a 6-month-old, they're behind on their shots, but they've said that they don't have any transport, and we just found out dad is in jail, and that's why mom couldn't come to the last 2 appointments. You know, the whole story seems to be set differently. And then the other piece that I've got out of this is when we first started, I myself truly felt, oh my gosh, we're opening a Pandora's box. How on earth are we going to help patients and families with all of these needs that they may have? We don't have the resources to help them. And what has come to me in the last several months is that we really don't even have to help them. It's just in the asking in itself that seems to make a difference to these families. And so they really are so truly grateful in just the fact that you asked, you've acknowledged, and that you know. And that itself is enough. You know, sometimes we apologize and say, I'm so sorry, I don't have a resource for that. They really don't even care. They're just so happy that you asked and you acknowledged that fact. And that really, to me, has been kind of path changing in how I approach with these patients.
Yeah, I would agree with that. You know, feedback from parents about screening for postpartum depression was universally positive. We didn't know what they think of their pediatrician asking those questions about postpartum depression in the mom. You know, same thing with screening for ACEs in the parent or caregiver. We didn't know what the reaction would be. One thing that Becky Haas said a couple times in our training is that these things, the families have already experienced them. The person has already experienced these things in their childhood. You're not re-traumatizing them by being an empathetic listener. You know, they've already happened. And I've found really universally with the parents in our clinic that they've been appreciative, and that just having, like Dr. J said, the opportunity to express this, and knowing that there's someone who cares, and if they need help, that they're there to help has been really positive. Anybody else with questions or comments? I know we ran about, we're running about 5 minutes behind, so, but if anybody else has questions or comments, we're happy to take them, or you can certainly also get in touch with me afterwards. Any other questions or comments? All right, well, thank you so much for joining us today. And I will say all of these sessions are recorded, and they can be found on the ETSU CME Project ECHO website. And then also don't forget to go there to claim your CME credit.
Thank you.
Thank you all, and have a great day.
Thank you.